Good morning, everybody. My name is Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute. I'd like to thank NetRF for the invitation to join you this morning to talk about new treatments and clinical trials. I'll be focusing on targeted therapies and chemotherapies. I want to start first by noting that there have been a number of advances in recent years in our understanding of neuroendocrine tumors as well as treatment, and there is a lot of work that is ongoing now to build on this progress, and much of the work is on clinical trials, which I'll provide an overview of today. I want to start with a few basic words about clinical trials and what they are and why they're important. So clinical trials are research studies that evaluate how well a treatment works in people. There are a number of different things that are being investigated, including optimal dosing of therapy, side effects, effectiveness of treatment, and then also how these treatments may compare to others that are available. Well-designed clinical trials are very important for us and also really the only way that we can continue to make advances in treatment and outcomes. So I want to thank everybody for their interest in this topic and also for participation. There are several phases of clinical trials, and they all vary in their aims as well as the number of participants. Phase 1 trials are trials that are relatively small that focus on safety and proper dosing of a therapy. Phase 2 trials build on this work with the dose that is established and focus on effectiveness and also characterization of side effects at that particular dose. Typically, these trials contain a few more participants than what we see in Phase 1 trials. Phase 3 trials are even larger that more rigorously evaluate efficacy and can also involve comparisons to other existing therapies. Some of the larger Phase 3 trials can include hundreds of participants. Once a treatment is available, continued work is done to better characterize not just efficacy, but also long-term side effects. And these types of studies can involve even thousands of participants. There are other elements of clinical trials that are also evaluated, including quality of life, patient-reported outcomes. Some clinical trials also build in biomarker studies that help us to better understand predictors of efficacy. And then some trials, particularly Phase 1 trials, also involve pharmacokinetic studies that can examine drug absorption, metabolism, and excretion. A lot of people ask, is there a clinical trial that's for me, and when should I consider a clinical trial? I think it is always appropriate to ask your clinical team if a trial is a good option for you. I think trials are particularly relevant at the time of a new diagnosis when initial therapy is being considered because a current therapy is either not working well or not tolerated well. So with that information in mind, I want to spend the next few minutes talking about clinical trials in well-differentiated neuroendocrine tumors. I'm going to start with this basic overview that lists some of the therapies that are commonly used to treat well-differentiated neuroendocrine tumors, which includes somatostatin analogs, and then also PRRT, everolimus, sunitinib, or CAPTEM. The options will depend based on where the primary tumor is. But these are all treatments that have been established to be effective in other clinical trials and are approved or commonly used. Some of the unanswered questions that are being investigated in some of the ongoing or recently completed clinical trials include, how can we optimize treatment with somatostatin analogs? How should some of these treatments be sequenced? Are there biomarkers that can predict efficacy and help with treatment selection? And can we expand treatment options for patients and add to this list of therapies? I'll start first with somatostatin analogs, which include octreotide and lanreotide, are commonly used as first-line treatment for advanced neuroendocrine tumors that are not able to be resected and where local treatment like liver embolization is not being utilized. Somatostatin analogs can slow disease progression, and they also can improve symptoms of carcinoid syndrome or other hormone syndromes that are related to hormone secretion. Much of the work done to establish the efficacy of somatostatin analogs was performed in GI and pancreatic neuroendocrine tumors. A clinical trial that was recently reported was the SPINET trial. This was a Phase 3 trial that evaluated lanreotide in lung neuroendocrine tumors. This study was unfortunately terminated early due to low enrollment, but the results of the trial were evaluated. Again, this was a phase 3 trial that evaluated lanreotide compared to placebo in patients with lung neuroendocrine tumors, both typical and atypical carcinoid tumors that were somatostatin receptor positive. The results of this trial suggested that there is also a role for lanreotide, not just in GI and pancreatic neuroendocrine tumors, but also in lung neuroendocrine tumors, particularly typical carcinoid tumors. Another trial evaluating somatostatin analogs that was recently presented was the Clarinet-4 trial. This was a phase 2 trial that was examining whether giving more frequent lanreotide could help in patients whose disease had progressed on standard doses of lanreotide, 120 milligrams every 4 weeks. Patients who were included in this particular trial had pancreatic and midgut or GI neuroendocrine tumors whose disease had grown on standard dose lanreotide every 4 weeks. They all received lanreotide every 2 weeks, and the primary endpoint of the study was to look at progression-free survival. So essentially the time from starting treatment until the cancer had grown a certain amount. The results of the trial showed encouraging progression-free survival results. So this trial, although not definitive, suggests that there may be a benefit for more frequent dosing of lanreotide in patients whose disease has progressed on standard doses of treatment. Another new clinical trial is also looking at a somatostatin analog. This is the Sorrento trial, and it is examining the efficacy of CAM 2029. This is a novel, high-exposure subcutaneous formulation of octreotide that can be self-administered by patients. This is a phase 3 trial that is evaluating CAM 2029 in comparison to what we standardly use, which is octreotide LAR, 30 milligrams every 4 weeks, or lanreotide, 120 milligrams every 4 weeks. This is designed to be what we call a frontline clinical trial. Patients cannot have had any more than 6 months of a prior somatostatin analog therapy or have had any other prior therapy where their cancer grew. The primary endpoint is to look at progression-free survival and to test the efficacy of CAM 2029 compared to octreotide and lanreotide. At the time of disease progression, there is an optional extension where patients can also receive CAM 2029 given at a more frequent dosing of every 1 week. So this, again, is a newly activated trial looking at a novel formulation of octreotide, which has the advantages of being self-administered to give patients some control over treatment. I'm going to move on to some of the other questions that are being evaluated in trials. One is related to sequencing of treatment, and others are how do we predict, or are there biomarkers that can predict efficacy and help with selection? Some of the trials that are comparing available therapies, the COMPETE trial is an international phase 3 trial that is evaluating the efficacy of PRRT with lutetium-177 etotriotide compared with everolimus in patients with advanced grade 1 to 2 gastroenteropancreatic neuroendocrine tumors. So the results of this study will help us to determine whether PRRT is more effective than everolimus or vice versa. This trial has completed enrollment, and we're awaiting the results. Another trial that is comparing available therapies is a newly activated trial. This is the Alliance A02-2001 trial. This is a randomized phase 3 trial of PRRT with lutetium-177 dotatate compared to capecitabine and temozolomide in well-differentiated pancreatic neuroendocrine tumors. And again, the results of this trial will be able to help us understand the comparative efficacy of these two types of treatment and also give us some prospective evaluation of the efficacy of PRRT for patients with pancreatic neuroendocrine tumors. Another trial that is also comparing PRRT to other therapy is the NETTER-2 trial. And this is a trial that is evaluating PRRT with lutetium-177 dotatate compared to high-dose octreotide LAR in patients who have GI or pancreatic neuroendocrine tumors that are more aggressive, grade 2 to grade 3 neuroendocrine tumors. And this is a group of patients who may benefit from earlier initiation of PRRT. So the results of the trial will hopefully help us to answer this question. The COMPOSE trial is another international phase 3 trial that is also evaluating the efficacy of PRRT compared to other agents. This, just like the NETTER-2 trial, is evaluating patients with more aggressive grade 2 to grade 3 well-differentiated gastroenteropancreatic neuroendocrine tumors. It is comparing lutetium-177 etotriotide PRT compared to chemotherapy, which could be either capecitabine temozolomide, FOLFOX, or everolimus. I do want to spend some time talking about this next trial, Alliance A021901. This is a randomized phase 2 trial that is evaluating PRT with lutetium-177 dotatate compared to everolimus in patients with somatostatin receptor bronchial neuroendocrine tumors. Much of the data that we have regarding the efficacy of PRT is in patients with gastroenteropancreatic neuroendocrine tumors. So this particular trial will give us prospective evidence of the efficacy of PRT in patients with lung neuroendocrine tumors, and then also how it compares to everolimus. In this particular trial, patients who are receiving everolimus will be allowed to cross over to receive PRT with lutetium-177 dotatate at the time that progression occurs. I'm going to next focus on a topic of whether we can expand treatment options for patients and add to the list of active therapies. A focus of clinical trial investigation relates to targeted therapies in neuroendocrine tumors. This particular slide shows a cartoon of a neuroendocrine cancer cell and the receptors that are on the surface of the cell, as well as some of the signaling pathways that are within the cells that can signal and drive growth. Some of the important signaling pathways in neuroendocrine tumors are the mTOR signaling pathway, which I've highlighted at the bottom, which is the target of everolimus. Tyrosine kinase inhibitors are a class of medicines that can bind to and inhibit a number of different receptors, but importantly, the VEGF receptor, which is one of the receptors that is important for signaling and driving angiogenesis, which is the growth of new blood vessels that can support the growth and spread of cancer. Tyrosine kinase inhibitors are used to treat neuroendocrine tumors now. The only TKI that is approved in the United States for treatment of NET is sunitinib, which is approved for pancreatic neuroendocrine tumors. There have been a number of tyrosine kinase inhibitors that have been evaluated in neuroendocrine tumors, including the ones I've listed on this slide: axitinib, cabozantinib, lenvatinib, pazopanib, surufatinib. All of these tyrosine kinase inhibitors have shown activity, although it's still uncertain where they will fit into the treatment pathway and also whether one is superior to another. Surufatinib is a tyrosine kinase inhibitor that inhibits several receptors, including VEGF receptor, FGF receptor 1, another receptor that's called CSF receptor 1. And this is a tyrosine kinase inhibitor that was studied in 2 phase 3 trials conducted in China that led to the approval of surufatinib in China. Both of these trials, the SANET-P trial, which evaluated pancreatic neuroendocrine tumors, and the SANET-EP trial that evaluated surufatinib in neuroendocrine tumors starting outside the pancreas, showed encouraging progression-free survival results and also an improvement in progression-free survival compared with placebo. These results led to the approval in China, but I think it's important to note that about a third of the patients who were treated on these clinical trials had no prior treatment. And in that SANET-EP trial, there were very few small intestine neuroendocrine tumors and mostly non-functional neuroendocrine tumors associated with no hormone secretion. And this is different from the typical extrapancreatic neuroendocrine tumors that we typically see in the United States. Although surufatinib is approved in Asia, this is not approved by the FDA for use in the United States. Earlier this year, the FDA had announced that it was going to await results of future clinical trials that looked at surufatinib in a population that was similar to what we see in the United States. Cabozantinib is another tyrosine kinase inhibitor that targets receptors including VEGF receptor, AXL, MET, and RET. This is a TKI that is being studied in the Alliance A021602 trial, also known as the CABINET trial. This is a trial that is evaluating cabozantinib versus placebo in patients with well to moderately differentiated neuroendocrine tumors starting in either the pancreas or extrapancreatic sites, including the lung, GI tract, or unknown sites. Patients who are enrolling on the trial will have received prior therapy, at least one prior FDA-approved therapy with cancer that has grown within the 12 months prior to entering the trial. There is a randomization, a 2-to-1 chance of receiving cabozantinib or placebo. For patients who receive placebo, there is an ability to cross over and receive cabozantinib at the time of disease progression. One other agent that has newly been approved by the FDA in the US is belzutifan. This is another targeted agent. This is an oral inhibitor of hypoxia-inducible factor HIF-2 alpha, which is involved in oxygen sensing. This was approved by the FDA based on the results of a phase 2 trial looking at the activity of belzutifan in patients with von Hippel-Lindau syndrome. This is a genetic condition that is notable for mutations in the VHL gene that lead to abnormal oxygen sensing and formation of tumors like renal cell cancer, kidney cancer, and also pancreatic neuroendocrine tumors. Some of the patients in this trial also had not just kidney cancer, but pancreatic neuroendocrine tumors. And patients with pancreatic neuroendocrine tumors had reduction in size of their tumors when treated with belzutifan. So this was approved towards the end of last year for VHL-associated cancers that were not needing immediate surgery. There is an ongoing trial that is looking at belzutifan in patients with pheochromocytoma paraganglioma, as well as G1 and G2 pancreatic neuroendocrine tumors, because some of the signaling pathways may also be active in non-VHL related neuroendocrine tumors as well. One other trial that I want to point out is the SWOG 2014 trial. This is a randomized phase 2 trial that is looking at postoperative chemotherapy in patients who have undergone surgery for well-differentiated pancreatic neuroendocrine tumors, where there is a high risk for recurrence after surgery that is defined by what we call the Zaidi score of 3 or more. That takes into account grade, that takes into account size of tumor. Patients who have up to 5 liver metastases that are removed at the time of surgery for their pancreas neuroendocrine tumor are also eligible. There is a randomization to chemotherapy with 4 cycles of capecitabine and temozolomide, or what we usually do in clinical practice, which is the standard, which is observation. So the results of this trial will help us to understand whether there is a benefit to receiving chemotherapy with capecitabine and temozolomide in patients where there may be a high risk of recurrence after surgery. We're going to end with a few minutes about clinical trials for poorly differentiated neuroendocrine carcinomas. The management of poorly differentiated neuroendocrine carcinomas primarily relies on chemotherapy, often with platinum-based chemotherapy, carboplatin, or cisplatin with etoposide. A subset of patients with poorly differentiated neuroendocrine carcinomas may be candidates for immunotherapy if there is a high mutational burden or if there is high microsatellite instability. One of the areas of clinical trial investigation recently has been whether there are alternatives to chemotherapy with platinum and etoposide, and also trying to better understand what the role of immunotherapy is. Trials that have investigated alternatives to platinum and etoposide recently have been a randomized trial that was conducted in Japan. This was the JCOG 1213 trial that looked at chemotherapy with cisplatin and etoposide compared to cisplatin and irinotecan. The results of the trial, which were presented at the early part of this year, showed that cisplatin and etoposide was not superior to cisplatin and etoposide. So for many people, cisplatin and etoposide remains a standard of care. There also is an ongoing trial that's being conducted in France that is looking at first-line chemotherapy with platinum and etoposide compared to a regimen that's called FOLFOXIRI. Recently, this year, the results of ECOG 2142 were reported, and this was a randomized phase 2 trial that looked at platinum with etoposide compared with capecitabine and temozolomide in advanced grade 3 neuroendocrine neoplasms. The results of this trial demonstrated that chemotherapy with capecitabine and temozolomide is not superior to platinum and etoposide. There is more toxicity with platinum and etoposide. I will point out that it will be helpful to review some of the subset analyses to look at the activity of these chemotherapy regimens in well-differentiated grade 3 neuroendocrine tumors compared with poorly differentiated neuroendocrine carcinomas, because these are very distinct disease entities. And it will be interesting to note whether one chemotherapy regimen might work well in one type of disease versus the other. For future clinical trials, I think we are also aiming to look at well-differentiated grade 3 neuroendocrine tumors separately from poorly differentiated neuroendocrine carcinomas. I want to add with a few words about immunotherapy in combination with chemotherapy. For small cell lung carcinoma, which is a form of poorly differentiated neuroendocrine carcinoma that starts in the lung, there have been trials that have shown that adding chemotherapy to platinum with etoposide in the first line setting can improve survival. So it is pretty standard to use chemotherapy and immunotherapy together for small cell lung carcinoma. We don't yet know for poorly differentiated neuroendocrine carcinomas that start outside the lung whether these results will hold true. So there is a recently activated trial, the SWOG 21-2 trial, that is looking at adding immunotherapy, in this case atezolizumab, which is a PD-L1 inhibitor, to chemotherapy with platinum and etoposide for extrapulmonary poorly differentiated neuroendocrine carcinomas, looking at it both in combination with immunotherapy and then as a maintenance strategy after the chemotherapy is done. So that was a bit of a whirlwind of all of the ongoing clinical trials in neuroendocrine cancers. I just want to end with a few words that these trials are really important for making advances in the treatment of NET. There are, as I've reviewed with you, multiple trials that are being conducted to help us evaluate new treatments and then also help us to understand how to best utilize the treatments that we currently have available, whether one should be used before the other or one is better than another. We definitely value participation in clinical trials, and I would encourage you to ask your NET team if a clinical trial is a good option for you. So I want to end with a word of thanks for your attention today and also for your contributions to both NET research and clinical trials. Thanks.